My name is Brady, and I've been asked and given the privilege of talking to y'all today about the disease of addiction. And the reason they selected me is because I am a doctor. I practiced family medicine for 25 years. Left there in 1992 to develop a program for doctors in the state of Kentucky with alcohol and drug problems. And over the next 17 years, we saw about 1,500 doctors in Kentucky with alcohol and drug problems. I left there and went into the prisons for 4 years. Now I spend 5 days a week. I and a couple of other people started a homeless shelter in Louisville in 1990. We sleep 500 men and women a night, and we've got 450 of them in a year-long program of recovery. There is a unit down the road here, a short piece, which was a spring off of that, and I come up there and talk periodically. So in 1987, I became a specialist in the field of addiction, and I've done that ever since then. Probably the best information I have about this is I'm a meth addict and an alcoholic. I've been clean from meth for 44 years. I've been clean from alcohol for 36. I have 2 children. My oldest one's 53, and she's been in recovery for 33 years. And I've got a 50-year-old son who's been in recovery for 30 or 31 years. Both of them had a major problem with alcohol and drugs when they were 11. Now, their mother and I were divorced, and she had some pretty strong evidence that she wanted me to stay away from them because on alcohol and drugs, I was a pretty messed up guy. So I didn't get a chance to see the children that much. And I did not know that they had that kind of alcohol and drug problem. I knew they were highly prone to have it because of the genetics of this illness. But I didn't get a chance to be a part of their lives for another 4 or 5 years. And then I saw the full-blown disease and was instrumental in, with their help in getting them the kind of help that they needed at that time. Libby when she was 20 and Burns when he was 17. So I'm kind of an expert. I've learned all the stuff, and that's what I'll transmit to you. I've lived all the disease, the family disease, the personal disease, the whole bit. I tell you, I was born and raised in a little town in western Kentucky named Mayfield, and grew up pretty much an all-American kid. I didn't grow up in an alcoholic home. The man for whom I'm named, my grandfather, died drinking bleach in the Mayfield City Jail in 1934. My mother was molested physically, emotionally, and sexually in that home, so she made a pact with Daddy that they would never see alcohol and drugs in the home. My daddy had 2 brothers, 2 of my uncles, who died from drinking. So I grew up in a really all-American home. No alcohol, no drugs, going to church, everybody loved everybody. We really did. It was a neat place to be. And was an all-American kid in high school, president of all 4 of my classes, all-conference quarterback. I looked like that one day I might be Pope, and I'm not even Catholic. I mean, I was that good a kid. Didn't have a problem with alcohol. Went to college and didn't have a problem with alcohol. I started my freshman year in medical school in 1958 at the University of Louisville. I was pretty nervous. My first gross anatomy exam, and one of the upperclassmen came down and gave me this little pill. It was called Desoxin. It's the closest thing we had in the 50s to methamphetamine. Nobody cooked at that time, and drugs weren't even a player to any significant degree. But they gave me this, said you can take this, you know it pretty much. It's a cousin to Adderall. It's a cousin to amphetamine. I took it to study, and I can remember the minute I took it. The world got quiet. I felt great. I didn't feel high. I just felt like I could study, and I wasn't scared, and everything was fine. Within a year, I was taking it all the time. I got kicked out of medical school 2 weeks before graduation in 1962. In a meth panic type of psychosis, I slapped one of my professors. They took me to the head of the Department of Psychiatry and the dean, and they asked me to leave school for 2 years. And I did, and saw 2 psychiatrists a week for those 2 years. Didn't take any drugs, got back into medical school, and in less than an hour I was strung out on amphetamine again, and didn't intend to be. But in walking back into that school with all the shame that I felt about being back and all the people that were looking at me and whatnot, I looked for relief and I took some pills. Now that sounds psychotic. When I go through this disease presentation, you'll have some idea about how the individual who's genetically predisposed to being susceptible to alcohol and drugs is basically anxious and sometimes depressed. My classmates enabled me. I graduated, did 2 years of residency, went into the Army. I was still on the drugs, almost got court-martialed in the Army. Spent 2 years when I got home in Our Lady of Peace, the mental hospital, and finally quit taking amphetamine in 1969. I didn't drink. Then I started drinking. Up until then, drinking wasn't a problem. I've not taken any more meth since then. The first 5 years of my drinking was fine. The last 3 years were absolute hell. I had a wife I've been married to now 36 years. It was my second wife. My first wife and I were divorced. She adored me. I adored her. Had a very excellent practice. The whole thing was right, except I couldn't stop drinking. Through a series of events at the end, and I mean one bitter night, the only way I knew to stop drinking, I'd had 9 years of psychiatric therapy, been deacon in 5 churches, and I'd never heard of AA, and I put a gun in my mouth and I was going. I was out of here. I couldn't stop. The reason I didn't pull the trigger was because of my children. I knew they would never know that Daddy didn't love them enough. And it was very important for me that those babies not be hurt. So I put the gun down, asked to go to treatment. I went to treatment, spent 4 months, came home, and I've been in recovery ever since, doing the things I need to do. Now they're going to show this film, if it turns out to be decent, all over the school system. And because of that, I can't mention some of the things that I do in my recovery because of the anonymity. And I protect that, but I will say it's a spiritual recovery based on having a sponsor, going to meetings, and basically carrying the message wherever I'm asked to carry it. And on this morning, it's with you. When I leave here, I'll go home, go back to the healing place, and do the things I need to do to carry the message. That's what I feel like I need. I should be dead. And the fact that I'm not, I need to tell the story to some people who may be ready to listen. And for those of you who just don't have the problem and you don't think you ever will have the problem, appreciate your courtesy and just listening, because some people in this room already do. The fact that you're as young as you are doesn't block you from being a part of the problem now, and I'll show you why there's an adolescent form of addiction and what the susceptibility is and what the individual drugs do. And all individual drugs, including alcohol, end up with a payoff in the brain the same place. And for those people who are susceptible, and we'll talk about who those people are, it's not even a crapshoot. The chances of your having a problem are virtually 100%. And I'll show you why that's true. The biopsychosocial model, alcoholism was defined as a primary illness, a standalone illness in 1955 by the American Medical Association. Drug addiction was defined as a standalone illness in 1987. It is chronic, progressive, fatal, and treatable. Chronic, no known cure. In your lifetime, you probably will see a cure for this disease. It'll be through genetic engineering. Right now, that looks like Frankensteinian research, and frankly, it is. But today, they can actually take a gene, and many of y'all are old enough to be studying some genetics, but the gene is basically the intact DNA messenger that carries everything that gets carried. And they can actually take a gene. We have approximately 20,000 genes with 15 billion connections. And they can take one of those genes and put it on a virus and run it in a mouse's brain, knock off various genes, replace them, and create an alcoholic mouse. A mouse that craves alcohol. Then they can turn around and reverse it. Within your lifetime, we will see when babies are born, we can run a genome on that baby and tell you with 100% certainty, because of the sequencing that's there in that genetic history, if that child drinks or drugs, they're going to have a problem. We'll be able to do it on you, on me. We already know the human genome. We now can do individual genomes, one on each one of you. But we're at a point where we can't interpret it that well. Reminds me of back in my practicing days when we had an MRI scan, you know, X-ray. It was a magnificent piece of ingenuity and technology. We just couldn't figure out how to read it. And it took them a while to learn how to read MRIs and CAT scans. Do the same thing with the human genome. 5 years ago, it cost $50,000 to do your genome. Today, they can do it for $1,000. We just can't read it that well. But we'll be able to. We'll be able to. So this disease is chronic, progressive, fatal, and treatable, no known cure. Progressive. If I start drinking again today, you'll see almost a Steven Spielberg, Dorian Gray change in me. It's as though something continues to go on in my brain even though I'm not drinking and drugging. In the late 50s, Dr. Jelnick did a curve of where he talked about in the adult alcoholic. That's the only person he was talking about. There's about a 7.5-year mean average of drinking, and then they literally fall off a cliff with progressive symptoms, and it takes that period of time, virtually that period of time, to get back to recovery, even without drinking and drugging. So this is a progressive illness. Fatal, 100% fatal, if you factor in trauma. Most of us know the effect on organs: heart, brain, breast, liver. What we don't factor in many times are homicides, suicides, and car wrecks. Once a month, I make rounds at the trauma unit at the University of Louisville School of Medicine. And at any one time, 65 to 95% of those beds are occupied as a direct or indirect result of alcohol and drugs. Even in people who don't have the disease. People who get hit by people like me who are drinking and run over them. Or if they don't have the disease and maybe they have 2 or 3 beers at a ball game, or they have whatever they may have, and they drive when they shouldn't drive. The term that's given to that today is harm reduction, teaching people not to drink and drive, even if you don't have the disease. If you have the disease like I do, no matter what you tell me, I'm not going to pay much attention to you, and I'm going to drive anyway. Praise God, I'd never hurt anybody, except me, but I had enough wrecks. It ain't no world record, but it's a good average. Because everything associated with reflex diminution, judgment impairment, all those things occurred, and I ran into things. So it's 100% fatal. It is eminently treatable. We're going to look at the biological, psychological, and sociological components. The sociological components: we live in an environment which not only condones drinking and to a great extent currently drugging, but we actually advertise it. You've seen the advertising. Life is better if you drink. One of my favorites is this incredibly good-looking bunch of kids like y'all, a little older. You're generally college age, and they're getting in this plane, and they fly out and they land in this azure lagoon, and they come off, and the guys all have a case of beer on their shoulders, and the gorgeous girls running along behind them. And that night they're sitting there in a sheet screen with a fire behind it, and you can see this couple lithely dancing, and these other couples in the shadows. You can only imagine what they're doing. And the next day it shows this incredibly beautiful young woman walking in the lagoon with a beer bottle in her hand and says they don't ever have to go back. Or this 6'2" female, gorgeous penthouse apartment. She's got a glass of wine in her hand looking to the city below her. Said, for the woman who can have everything. Everything is seductive. The drugs. You know, what y'all are hearing is that marijuana is not a bad drug. That's just what, you know, we're doing it now to help people. The only place that marijuana is effective medically, the only place, is in the wasting syndrome, terminal cancer and terminal AIDS. But now we're passing it out for nervousness, anxiety. It's money. And to say it's not harmful. The chances of irreversible schizophrenia from smoking marijuana has now been published in the last 6 months. We don't know if it's dose-related and time-related, and we don't know who's susceptible to it, but we know it's happening. We're seeing with it what we saw with LSD 20 years ago, with, in that case, irreversible schizophrenia. We see major cognitive defects. This is all evidence-based research published in the medical journals. But you're getting the message, it ain't a bad drug. It works like any other drug. It increases the brain chemistry that the person who's genetically predisposed will not have in the same amount. But with the pot, with the alcohol, with the marijuana, with the cocaine, with the heroin, even with nicotine, there's an increase in this particular chemical called dopamine, which we'll look at. And that's what the person who's genetically predisposed wants, because it calms everything down. Life's not scary anymore. And if you don't have that, you don't know what scary is. I've lived scared most of my life. The term given is irritable, restless, and discontented, anxiety and depression. And most of these drugs, when they work, virtually all of them, make that better, because it changes the brain chemistry. Peer pressure. I went to treatment when I came back, and we think this peer pressure is just with kids. That's not true. It's true that it's there, but that's not the only place. When I went to treatment, I was 41 years old and had the world by the tail. Came home, I was president of the country club. I made a reputation as a hard-drinking, hard-charging type of guy, and came back from treatment. The guy met me going into a board of directors meeting, at a martini in each end. He said, could you drink this? And I'd never met him. He's a new member of the club. And he said, could you sit with me and talk and drink this martini? And I said, as soon as this meeting's over, I'll be glad to talk with you, but I can't drink that martini. He said, I've heard about you. You can drink this martini. I said, no, I can't. He said, why? And I said, I'm an alcoholic. And he looked at me like I just kicked him in the mouth and said, congratulations. They don't know what to say to us, you know. But I wanted that drink, didn't I? Not because of the drink, but because I didn't want to be less than, rejected by, different from. So it doesn't happen just young people. It happens in anybody, especially if you're prone to be living in a world that's too loud. This is the psychological component. There's no more mental illness in addiction than there is in the normal population. You're not going to get everybody to agree on this. But when people have seen what I've seen, and I mean literally thousands of alcoholics and drug addicts, street people, prisoners, doctors, then you begin to know what research is telling you what's real and what research is telling you whatever they're telling you for whatever reason they're telling you. There's no more mental illness in the alcoholic, addicted, and drug addict population than there is in the normal population. That's talking about schizophrenia, bipolar illness, and things that are true mental illness. There is a significant increase in affective mood disorders. That's anxiety and depression. These are the different forms of how anxiety presents: obsessive compulsive, panic, sociophobia or agoraphobia, PTSD. No one has given proper credibility to the fact that post-traumatic stress is a major piece of trauma as a child, sexual trauma, physical trauma that may create this in someone who's genetically predisposed, or in most of the adult form of addiction, the things that we've done when we're drinking and drugging that we're so ashamed of that it creates a total post-traumatic problem. And if not dealt with, there will be chronic relapses. Chronic relapses. And in generalized anxiety, and in situational familial depression. At one time we thought there was a significant increase in ADD and ADHD. We don't think that today. But even if we see symptomatic stuff that looks like it. It requires adequate testing, and if there's a family history of addiction, or if there's a personal history of addiction, we don't allow, or should not allow, stimulants to be given. That's Ritalin and Adderall. Now, if you don't have a family history of addiction, individuals not addicted themselves, of course they can use that. And they're not running a higher risk of addiction. But that's just what we have to be aware of. Research done in the 70s showed that an alcoholic and drug addict has a compromised relationship with a parent of the same sex. My daddy's the finest man I've ever known. It can happen through death. It can happen through a number of ways. In my case, it was the Depression and World War II. My daddy wasn't there. So my mama raised me. All my male skills came out of dirty books and locker rooms. I played my first football game when I was in the 3rd grade. The whole idea of recovery is to develop a relationship with significant same-sex surrogate parent or with their own parent if that can be done. Genetics and biochemistry. Adoption studies done in 3 different Scandinavian countries from 1935 to 1950 show if you have a primary relative that's an alcoholic or drug addict, most of that was alcohol because it was a period of time when drugs were not an issue, chances of that child becoming an alcoholic or drug addict are 4 times greater than the normal population, whether they're raised in that home or not. Stimulus augmentation. We have brain waves showing that the alcoholic and drug addict has abnormal brain waves that have to do with stress reduction, and the offspring of those same parents are more prone to addiction and have the same brain wave abnormalities in most of the cases. The textbook of Alcoholics Anonymous talks about young people will drink differently from older people. In 1981, a fellow in St. Louis named Cloninger began his studies and defined 2 types of alcoholics, and therefore the same extrapolated to the drug addict. Type 1, which we don't see, is considered to be the adult form. 7.5-year mean average of drinking, social control, don't try their best not to screw up their life and other people's lives until they can't keep from it. Usually older than 25 years of age. The part that will be pertaining to you is the so-called type 2, highly heritable adolescent form. Seen 9 times more frequently in families where there's significant male alcoholism for boys and significant female alcoholism for girls. Early onset, less than 25 years of age. Most of the time it's less than 15. Sometimes it's less than 10. They do not lose the control of the amount they consume if it's alcohol. Drugs will make that a little bit not this clear, but with just alcohol, they don't lose the amount that they consume. They may not drink that often, but when they do drink, they lose social control and they wreck cars, whip people, shoot out windows, and right now most of them end up in prison. 5 years I spent at prison working out, it looked like, many of their little faces looked like y'all's. They were kids. There's a unit on LaGrange Road in Louisville that has 30 young people, literally all under the age of 20, who have the equivalent of 2 felony charges. And they put them in there as a diversion program because they're adolescent alcoholics. And they've hurt people. They had to be intervened on because of their lack of social skills and an inability to control their behavior. From a brain chemistry standpoint, it's different from adult alcoholism because of a screw up of one of the brain chemicals called serotonin. The big one in addiction is dopamine, but in the adolescent alcoholic, it's a screw up of serotonin. And the kids didn't cause it, they inherited it. But because of the way this works, they're just like, they're loaded for bear all the time. Throw alcohol on top of it, and it'd bring tears to your eyes. Because you know they don't mean to do it, but they're completely out of control. Back that up for me, please. This is a very schematic drawing of a brain, of a nerve in the brain. That lower thing is called an afferent neuron. Then you see that little place there where they don't touch, that's called a synapse. That other nerve is an efferent neuron. The afferent comes into the brain, the efferent goes out of the brain. That's the way the brain works. The way I like to say this is the bottom one is Covington and the top one is Cincinnati. And that's the Ohio River between it. That's the cerebrospinal fluid. That's the way it works. Now, if there's a load that you want to take from Covington over to Cincinnati, you put it on a boat. Now, we're going to play like there aren't bridges, okay? You put it on a boat and you carry it over to those little hair-like follicles. Those are called receptor sites. Turn around to come back, and it's reuptake. That's dopamine. Those are the boats. That's the neurotransmitter, and it's ready to go. Put cocaine in that system. Jumps in there, goes over to Cincinnati, comes back, cocaine's blocked at reuptake site. And the dopamine goes sky high. Wow, I'm making good time. I don't know where I'm going, but I'm going to be first. There you are, you know. And for the person who's low in dopamine, and everyone who's prone to addiction will be, that feels great. That's the answer. The pill, when I was taking the gross anatomy exam, I felt good. I wasn't scared. I could do what I had to do. The brain puts that in there and never forgets it. It's called euphoric recall. And under certain conditions, that memory will come back. And when it does, if things aren't in place, these individuals will relapse. All of us are born deficient in dopamine who are genetically predisposed to this illness, and all drugs of reward increase it. This is the big boy, big girl version of the same thing. It shows how the brain's all interlocked, and if you're an alcoholic, you'll be a drug addict if you use drugs. If you're a drug addict, you'll be an alcoholic if you drink. These are all the neurotransmitters. The top one has to do with tranquilizers. The bottom one has to do with opiates and heroin. The brain has its own heroin. It's called endorphins. It has its own receptor sites. You put heroin or you put hydrocodone or you put anything in there, it's going to tie up that mu receptor site. One of the drugs that has an affinity for that mu receptor site of the opiates is marijuana. Marijuana ties that up. That's why it works in pain. You'll notice at the top that, and you can't see it, they're called amines. Alcohol, cocaine, pot, narcotics, nicotine, all increase dopamine. Serotonin, you're aware of. I just told you it plays a part in adolescent alcoholism. You know it because of Prozac, Zoloft, and Paxil, whose purpose is to increase serotonin. They're not addicting. The rest of them don't matter. The dopamine matters 100%. This is a schematic drawing. If I cut my brain right here and cut it right here, it's called a hemi or half sagittal section. I'm looking right down on the top of my brain, and on this drawing it's the left side. All drugs of reward increase dopamine by getting into this ventral tegmental area. This is the pleasure system of the brain in the human. Everything that creates these connections is dopamine. The brain fibers that go to the top that you can't see go to the cortex, usually the prefrontal cortex that controls impulsivity. The nucleus accumbens is a remnant from lower animals which controls pain and pleasure. In the human, that little stippled area is called the hippocampus. It's the seat of memory and retention of new information, what you're studying in school. Marijuana wrecks that entire system. Through the cannabis 1, cannabis 2 anandamide system, which is the brain's own marijuana. And exogenous marijuana competes with those receptor sites. That's why marijuana has been labeled the stupid drug, because of performance effect. And it occurs in this area of the brain and messes up the memory system. The lower part there is called the amygdala, and that has to do with emotions. This is the extended amygdala system, the pain-pleasure system, all run by dopamine, and if we're born short in dopamine, then all those drugs and alcohol will increase it, and we're off and running. These are the chromosomes we see in genetics that are screwed up that we know today. This is the brain on cocaine. We can use it for any drug. The one on the left is not on cocaine, and that red stuff is dopamine. On the right, you see the dopamine is depleted because the minute the dopamine goes up, the brain resets itself and leaches the brain of dopamine. So that person who's so high and feeling so good within a short period of time, I don't feel so good. Another hit, feeling great, don't feel so good. Another hit, I feel great. Another hit, I don't feel so good. That's addiction. Seeking of pleasure, the avoidance of pain with complete disregard for the consequences. This is the biochemistry of alcohol, and this is important, and you'll see why. Alcohol is metabolized acid aldehyde in the liver to acetic acid to CO2 in water. We blow it off through the lungs, and we urinate it through the kidneys. Alcohol is first metabolized at the stomach level with an enzyme called alcohol dehydrogenase. Women, by genetic influence, even non-alcoholic women, have a decreased amount of alcohol dehydrogenase over men. Alcoholic women have virtually no alcohol dehydrogenase. The textbook of AA says women will be affected much more severely, more quickly, physically than men. And the reason is because, we didn't know it for years, the reason is because they don't break down the alcohol in the stomach, and they get in the first 3 passes of metabolism, or at least the first 2 are high octane alcohol. Incidence of breast cancer in alcoholic females is way beyond non-alcoholic females. It's because of the effect, bombarding effect of alcohol on the breast. We see much more wet brain syndrome. About 2% of people will have dementia, virtually, well, more than that, but it's called wet brain syndrome. We see it in women more frequently because of the effect on the brain. In recovery, and you don't see this in young people as much as you do in older people, retentive memory, this is after detox, this is after treatment. Retentive memory for recent events. This is antegrade memory, learning new information. If I know how to ride a bicycle, I can ride a bicycle. When I came back from treatment, I knew how to practice medicine, so I could, but I couldn't remember where I parked my car. When we built the healing place, we built it to be for a year, so their brain could heal. The long-term residential treatment programs today do it for a reason, to let the physical effect on the brain heal, because it continues for 6 months to 2 years in the adult. In the adolescent, we don't see it. We see the effect of the drugs, and we see it with the effect of alcohol, but not like in the adult. Sleep patterns will be screwed up. Simple problem solving and stress management, those are physical effects of the drug. They will clear. Unless an individual has a wet brain syndrome, they will get it back. If any of you in this room have a problem with alcohol and drugs and you're wondering after this talk, will my brain come back? Yeah, it will if you'll stop. But if you got the same disease that I've got, rather than just experimenting, you're going to have a tough time stopping without help. It's just a fact. I know all the textbooks, but I learned it with my babies. What I could do something about and what I couldn't, and what they had to be taught. And most of the time I couldn't teach them. They had to learn it from professionals and someone that they didn't have a lot of the emotional involvement with. But Libby, someone asked her when she was in recovery about 6 months, about 6 years, they said, what was the main effect on you getting sober? And she said, my daddy. I said, what does that mean? She said, when he was drinking, I hated his guts. He'd tell us he'd show up, pick us up, and he wouldn't be there. If he came, he might be drunk. So he didn't beat us or scream at us. I couldn't trust him. I didn't know what would happen with him. Said he got sober, and he said, I'll pick you up at 6. He picked me up at 6. He said, when I had my problem drinking, she said when she had her problem drinking, she knew she wanted to be just like Daddy. She wanted to be accountable and responsible, and she knew she'd gone way past that point. And she was in college and doing okay. Treatment is abstinence. Short-term detox, intermediate evaluations to determine what level of care, and long-term can be whatever it needs to be. Outpatient, inpatient, whatever. We do have time for some questions. Any questions?
Like, let's say your mother was an alcoholic and then her son was worse and then his son will get worse. Will that keep happening because of genetics?
Question is the genetics passed through generations? Is that the question?
Of alcoholism or something?
Yeah, of alcoholism. The disease of addiction is passed through generations. It may not show in each generation. For instance, I didn't see it in mom and dad, but they didn't drink. Would they have had the problem if they drank? I don't know. From the way mama acted, I think she probably would have, but I don't know. But, you know, but my grandfather had it. I didn't grow up around it. I've got it. Both of my kids have it. My brother had it. Both of his kids had it. And if you're looking at the kind of homes you want to be raised in, you'd want to be raised in our homes. You know, we had the funds to make life better. We had the education. We had the intelligence. We had the attitude. Didn't stop it. Does that answer your question?
Yes, sir.
Yeah. It can skip generations. Now, with the human genome that we're studying, we'll be able, through sequencing, to know what actually happens that allows it to appear to skip generations. But I think we'll running the social histories and looking at this sequencing, we'll be able to nail it exactly, but it may skip 1 or 2 or 3 generations, and all of a sudden there it is. I don't know how many people I've talked to that says, there's never been any alcoholism in my family. But when we sit down and do a genealogy, they find it. It may be Aunt Sarah that they kept in the attic for 60 years, but it's there. Just had to find it. Does that answer your question?
Yes, sir.
Yeah. And when I'm talking with y'all today, and many of you already know and listen to it, that you've got a risk factor, or you may already be playing, or you may have a problem. Or you may know you're in a gene pool that makes this a high risk. So what you're learning today is not just about you, it's about your children. When you start thinking that this is a presentation just for you, it's not. It's for your children. It's for 2 or 3 generations from now. Because the predominant factor in who will have the risk factors is genetics. Anybody else? Thank you. Yes, sir.
What is dopamine?
Dopamine is called a neurotransmitter. You know, what I showed you, those things I put up there, mu receptors and things like that, those are receptor sites for those chemicals in the brain that are neurotransmitters. To show you a breakdown of what was there, but I think this will be easier to see. The neurotransmitters are, as the name implies, they transmit the nerve impulse, because the nerves don't touch. So when we send the impulse through here and it comes out through here, you got these receptor sites and then these reuptake sites, and dopamine's sitting here to be a neurotransmitter, and when it goes out, it becomes active, carries it over here and carries it back. That's a neurotransmitter or a nerve impulse carrier. And that's the way the brain's set up. The brain has its own, basically has its own cocaine, meth. It's in the stimulant system. The dopamine system has its own heroin, as I said. Those are the beta endorphins, the methionine and enkephalins, and then the opiate receptor sites. Marijuana has its own system, anandamide and CB1 and CB2. Every one, the brain is set up with virtually its own system of all the chemicals we can be addicted to because of the neurotransmitters. and they carry impulses. And like I said, when you got cocaine in here, it'll block this reuptake. So here comes the dopamine. It can't be reabsorbed and ready to go again, and it goes sky high. And when you're starting off with a decreased amount and irritable, restless, discontented, that's what we're looking for. You know, I'm sitting there flying apart, getting ready to take my gross anatomy exam. I wasn't an addict at that time. I didn't have a problem. But I've got this genetic background that makes me anxious. I'd known for years I was more anxious than most people. What I do, I just got more productive. If it bounced, I played it. If it was not a season for a sport, most of them were there, I acted in the plays. I debated in the debate team. Move, 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 move. And we know that movement will increase beta endorphin, will also increase dopamine. I mean, we know that happens. And I learned, without even knowing what the problem was, movement made me feel better. Getting tired made me feel better. So when I took that first pill and the dopamine went up, I felt better. Now, there's a lot of complicating things in here that I can get into with you, but the take-home message is around the neurotransmitter dopamine. And all drugs, alcohol will increase dopamine by direct stimulation. Heroin, all the opiates increase it by blocking certain interactive things that increase, and they'll increase dopamine, but they all increase dopamine. This is the risk of medication-assisted recovery, such as methadone and Suboxone. You may not have heard of those, but they basically are to go in there and tie up the opiate receptor because it is there, but that'll increase dopamine. And people almost always relapse on that. And there's a big fight in addiction medicine. Is this medicine indicated? And I mean, it has separated the addiction field. There's no doubt in my mind, not because of a theory, I know why it does it, but because of what I've seen. The people in the prison, I say, were you ever on Suboxone? Were you ever on methadone? Yeah, how'd it do? It didn't work. It's a joke. And the reason we know is because it increases dopamine. May not relapse to the opiate, but you're going to relapse to something else, usually to alcohol, maybe Valium or Xanax, you know, but something else. If everything is predisposed to feeling anxious, depressed, irritable, restless, discontented. Does that answer your question about what is dopamine? Or what is a neurotransmitter, basically. And like I pointed out, the dopamine is the stimulant. You've also got the beta endorphin. Those are the opiate ones. And you can go right on down the line. They all are what carries the impulse to certain areas of the brain. Great question. I'm sorry I didn't get the job done the first time. Did that clear it up for you? Anybody else? Ask them, because I'm 78 years old and I may be dead before you ever get a chance to hear me again. I don't want any clapping when I make that statement, but the ones who really care, you got any question. The question is, how does the brain reset itself? When we put cocaine in there and it can't be reabsorbed and the dopamine goes sky high, the brain, have y'all studied anything called homeostasis in science, where everything balances itself out? The brain is set up so that stimulants offset the sedatives offset the stimulants, and that's the way the brain, it's an incredible act of nature. It's called homeostasis. Well, even if the individual is born genetically deficient in dopamine and they feel irritable, restless, discontented, the brain still knows that's the normal amount of dopamine. And when the dopamine goes sky high, the brain resets itself. You know it, and most people know it as tolerance. You have to drink more to get the same effect. You have to smoke more dope to get the same effect. If you're using other drugs, you have to take more to get the same effect. And the reason is because the brain resets itself. Once hey, I feel great. The brain says, whoa, let's get this thing shut down here so you don't feel as good. And another hit. So the second hit doesn't get quite as much. Brain resetting or tolerance. Most of the people who die of opiate overdoses are not committing suicide. They've been off of the opiate for a while and they go back and use the original dose and the brain has reset itself and can't tolerate that increased dose that they got to down here. It's back up here. And what happens in resetting itself is that the brain, so that you don't get more dopamine, will knock out some of the receptor sites. This nerve will swell so it can't conduct as well, and there's a whole side reaction to decrease the dopamine. The brain resets itself, gets itself back to where it's comfortable. It doesn't feel threatened. This increased dopamine is something the brain doesn't want. Now, the addiction center, the pleasure system does, because that's what we want to feel. I mean, even for normal people. Now, you have a drink, have a couple of beers, and you think, or have a beer, and you think, yeah, I feel pretty good. It doesn't come through the dopamine system. It comes through a system that is the brain's own Valium, called GABA. Normal people come in after a tough day and they have a drink and settle down before they have dinner. It's not going through the dopamine system, it's going through the GABA system. That's the brain's own Valium, its own tranquilizer. And alcohol has a strong affinity for that receptor site. Alcohol is water soluble, so it goes anywhere it pleases. Most all the other drugs are fat soluble. They get distributed in the fat, but alcohol's water soluble. It goes anywhere it wants to go, and it has a huge affinity for this. When we detox somebody, what we do is say they're on alcohol. And we know it's really screwed this system up. So we take them off the alcohol, put them on Valium, which is dry alcohol, taper them off, and that's called detox. 15% of people who quit drinking abruptly will go into DTs. 15% of those people will die. Coming off of the other drugs, it's not life-threatening. Most people won't come off of them because it's too painful. But they won't die. But 15% of people will die coming off of the alcohol and Valium or the tranquilizers. Does this answer the question about the brain resetting? Yeah. And again, Debbie, when she pointed out to me some of the questions that have been asked to her over the time in talking to y'all, will it come back? The brain will heal itself. It's called neuroplasticity. Have y'all studied that? Okay, it's called neuroplasticity. When I was in medical school, we were taught that the brain won't regenerate itself, like closed head trauma or something like that, and there's parts of the brain that are hurt, and we were taught it wouldn't regenerate. Now we know it will. It'll short circuit, recircuit, but it'll regenerate itself. It's called neuroplasticity. Y'all mean more to me than I can possibly tell you. You can decide whether you believe that or not. I've been in places talking to people that if I told you, you'd be impressed out of your mind. And with the exception of the prison and the healing place, this is the most important place to me that I know, and probably if I were around you more, this would be the most important place. Because you've got an incredibly beautiful life ahead of you. But if you're genetically predisposed and get into these mood-altering, mind-altering medication, it can create an Armageddon for you that is optional at the beginning. One last thing, if those of you who are research-minded, if you want to go to the research place to find what is best that we're talking about in this addiction field, go to the Journal of the American Medical Association. The seminal group of experts is called the American Society of Addiction Medicine, ASAM. And they are the cognoscente of addiction. I appreciate very much y'all being here and your courtesy. Thank you for letting me come.